able to, to walk away with that, walk away with some tips, so that at your own practices, you're able to really come together as a team, to meet the needs of our survivors as they move through long-term survivorship. So today, what we're going to do is we're going to, like we did last time, we're going to start off with a case study, and we went back through all the survivors that we've seen over the years, and we chose this particular case because the person presented to us, kind of with a very heightened level of anxiety, and it was very interesting to all of us as providers of how that presented to us, and particularly when it came to this person's diet and her exercise habits. It was very, very interesting to see how she was manifesting this anxiety and this fear of cancer coming back, and all the ends that she went to make sure that she wasn't going to get the cancer again. So with that, Maura, I know that you were going to kick off for us today, and
can I interject real quick?
Of course.
We were also hoping, I think, at the end of this case to, ask you all to reflect if any of this resonates with you. If you've seen anyone that you feel has a fear of recurrence, and how that might have manifested, to share that with us before we go into the didactic. Is that okay to say? I think that's what we had decided.
Oh, absolutely. Yes, we want. Very good point, Dr. Sampton. Yes, we definitely want your feedback, because we're sure that you probably have seen somebody similar to this in your practice, and so let's keep the conversation going after we present the case study here, because it'll be interesting to see how everybody has dealt with that in the past. So Maura, go ahead.
Okay. This was just a fascinating case, and I think as you listen to her course of treatment, keep an ear out for how these things can contribute to her fear of recurrence. So this patient was Ms. R, and Ms. R, and she's a 63-year-old woman who self-referred to our clinic. And it was 4 years since her diagnosis of a stage 1 breast cancer. Now, remember her age because it's significant to her family history and to her story of fear of recurrence. It turns out that the stage 1 breast cancer was not her first breast cancer diagnosis. It was her third. 4 years prior to that stage 1 diagnosis, she had DCIS in her left breast. And 5 years prior to that, she had DCIS in her right breast. So she really presented to us in her 16th year of her survivorship journey. With the first DCIS, she had a lumpectomy and radiation. With the second DCIS, she actually had a bilateral mastectomy. And then 7 years later, she had a new primary stage 1 breast cancer, which they determined arose from the axillary tail of residual breast tissue. So you can imagine, she thought she was doing everything she could, and she got a third episode of a new primary breast cancer. She then went on to a course of chemo after that, and and then she presented to us. She was on an aromatase inhibitor since she had an ER positive type of breast cancer. She also had a significant family history of a variety of cancers. Yet you can scroll down, yet the genetic testing done at that time was all negative. But of significance is that it was her mother who had metastatic breast cancer and died at age 63, the age that this patient came to our clinic. So you can scroll up back a little bit. So given her long course of treatments and seeking answers, she sought out alternative care from an online natural healing center in Oregon. There you go, during her lifestyle, under lifestyle. She was prescribed 50 pills and 241 drops of various herbal preparations a day. She was required to follow a strict schedule of administration throughout her day of each pill and drop before, during, and after every meal. Now, among these preparations was a milk thistle. And as I'll explain later in the didactic, milk thistle is contraindicated with aromatase inhibitors. In addition, she was instructed by this natural healing center to cut her aromacin dose, in half. So when she presented to me, she actually said that she felt like she had an eating disorder. She had eliminated all dairy products. She ate only organic foods. She had a very limited and strict regimen of the foods she ate. She lost all pleasure in eating. And the one thing she said was she really missed ice cream. Her weight was stable, but she had a BMI of 19.8. So in my evaluation of her, we actually have a system of diagnoses in nutrition, and I was able to assign her a nutrition diagnosis of excessive bioactive substance intake related to a fear of food for recurrence of cancer, as evidenced by severe restriction and regimentation of types of foods consumed. So in this case, this woman, who rightfully so had a fear of recurrence, considering she did everything she was told to do, and it's still, she then just started to reach out to trying other things and going out online and going in and getting this guidance of people telling her things that she needed to hear. And she ended up in a very bad place nutritionally. She was on her way to becoming malnourished. So that's how far a fear of recurrence can drive someone. This is an extreme case, but it's not the only one I've seen. So with that, I'll pass it off to Scott, and he'll talk about how this fear of recurrence manifested in her exercise. You're muted, Scott.
You think I would know how to use Zoom by now. So yes, so thank you, Mara. So, as extreme as she was, with her intake of all these supplements and these pills and everything, she had actually done kind of the same thing with her exercise. Again, she thought that she had done everything the right way, and she still got this third diagnosis of cancer. And so she actually became one of these excessive exercisers. And as you saw, her BMI was under 20. So she was constantly exercising, like several hours a day. So kind of like that obsessive need to continue to exercise, thinking that it's going to, drive out the cancer, that it's going to prevent a fourth recurrence of the cancer. So with her, I mean, she's definitely the other side of the pendulum, right? I mean, for so many of our survivors that we're working with, they're on this side of the pendulum where we're trying to get them into an exercise routine, and we're trying to move them to, making lifestyle changes so that, they meet these ACSM recommendations. But she was over here. She was so far to the other side. And because she was exercising so much, she was actually giving herself a whole bunch of traditional musculoskeletal injuries. She was having knee pain, she was giving herself shin splints, ankle pain, because she was on the treadmill for an hour, and then she would go get on the elliptical, and she would literally kind of like bebop around to the different pieces of equipment at the gym. And so, for her, I had to actually rein her in and say, yeah, you're, at first validate, everything that she's doing, but then realize and tell her, okay, you need to actually come back a little bit, because you're doing so much that you could actually be doing your body harm in the musculoskeletal sense of things. So to try to strike that balance with her, again, I had to meet her where she was at that point, validate her concerns, but then talk to her about how do we kind of rein that in so that it actually is more doable. So again, so that she would actually, and try to enjoy life a little bit more. Like Maura said, like she was missing out on having ice cream, and who doesn't like to have ice cream once in a while? So, we don't want people to feel like they have to be exercising 5-6 hours a day, there is a healthy balance to strike with that. So this patient, again, Maura and I saw this patient several years ago, before Angela and Jevin were part of our team. But I'm going to ask first Angela and then Jevin, if this person was sitting in front of you in clinic, like if we had this person come to clinic now, just kind of quickly, kind of surmise, what would be your approach to this particular patient, and then we'll go more in depth in the didactic.
Thanks, Scott. So for me, clearly just starting where she's at, just listening to this patient presentation, she clearly has a significant level of anxiety and a severe level of what we would call fear of cancer recurrence. And just like Maura indicated, she nutritionally is challenged. She's also emotionally challenged as well. And so my role would be, talking to her about her fears and where they're stemming from, and to teach her some coping strategies on how to manage this fear of recurrence. But clearly there was even some obsessive behaviors here where she was researching the internet, and she found a place in Oregon, clear on the West Coast. And so, and was taking these 50 pills and these 241 drops. And not to mention, she was younger when she was initially diagnosed, in her early 40s. Her mother passed away from metastatic breast cancer, and she's got a family history. So all of those are vulnerabilities. They're indicators that would make somebody more vulnerable for developing fear of cancer recurrence. But in her case, it's more of a severe form. What I do know about this patient, and just reviewing her medical record, is she was strongly encouraged to seek out mental health counseling on numerous occasions, and she declined. So knowing that about her when I met her, I would have continued to have that conversation with her and explore maybe why she was somewhat resistive to getting that help. But her quality of life was greatly impacted. And it seems like all of the focus of her life was just cancer prevention. So, and I think, Jevin, did you want to? Okay.
Yeah, thanks, Angela. Yeah, so, going off of what Maura and Scott were saying about her when she had presented, she had a lot of habits with her nutrition and her exercise habits that were fed by fear of recurrence. And part of that, what stands out to me is the fact that she had DCIS twice and then had another primary breast cancer with invasive disease. And so I think highlighting, what her risk of recurrence actually was and providing that information to her and giving her that level of reassurance that it was nothing that she did wrong that led to this new primary breast cancer coming up. I think that can go a long way with helping to relieve some of that fear of cancer recurrence, as we'll get into a little bit more in the didactic as well. Tara, I don't know if you had wanted to chime in as well.
Yeah, I agree with everything that's been said. I get curious when I hear stories like this, how was she received at the oncologist's office? Because my guess is, and we're all vulnerable to this, they see a woman who's, thin and fit and exercising all the time, and they're like, great job, you're doing a great job. You look like how we want all of our patients to look. And we've seen this with other cancers as well, where the survivor looks really good. And so they it's like an easy visit, right? Like, oh, she's super healthy, so no evidence of her disease. And then they don't, but we miss big cues that this is actually paralyzing to her. Or, other functional, I look good, but in the case of another patient who's had part of their lung removed, I can't walk. I used to run marathons, and now I can't walk 3 blocks. But they look good. So you don't get those stories until you come to a clinic like this. And we all know that cancer recurrence, the fear of it doesn't matter what your actual risk is. It's pervasive if you're stage 0. Sometimes it can be disabling. So I think we'll talk about all of that, but thanks for letting me chime in. And I'd be curious to hear from the group if any of these stories resonate with you, if you've seen any of this in your own practice.
So we'd love to hear from any one of you if you had any thoughts on this or commentary. Kathy, yes, go ahead. Go ahead and unmute. There you go.
So I'm a 3 or 4 year breast cancer survivor, and this person's me on steroids. So I had all that stuff, not all of it, the eating and exercise regimen, because those are the 2 things I can control. So I completely relate to how she came in, and would have really benefited from this kind of situation instead of me going. I picked a lot of it up at PT conferences, and that's what settled me into my new normal, which helped a lot. But there's so much stuff on the internet, and a clinic like this really grounds you. And Dr. Sam's comment about the oncology office is all too true. They don't ask probing questions, and aside from how you look and your blood pressure and your lungs, you're good. So and this past so I never really had any of this, but so I developed lymphedema this past winter over COVID because my exercise regime changed and did too much. So again, education goes a long way.
I think that's a great point, Kathy. The fact that what you said initially, I thought was amazing. The fact that it was what was within your control. And that's something that is a key component in managing fear of cancer recurrence. And it's something that we're always, as a team, reminding our survivors when they come through, that these are lifestyle changes that are within your control rather than focusing on what's not.
Yeah, and Kathy, thank you for sharing your story. It's truly amazing. Thank you for all of that. One of the other things that I want to pick up on that you said, was the whole fact about the internet. And Maura, I know you refer to it all the time as Dr. Google, and there's so much misinformation that's out there, and I know a lot of our patients will, kind of get hooked into some of these chat rooms and groups and that sort of thing. And, a lot of times they hear, the worst case scenario, right? And so really it's up to us as the providers, regardless of what our profession is, whether we're PT, dietitian, social worker, PA, MD, whatever our qualifications are, it's our responsibility to weed through all of that and dispel all of the misinformation that's out there. So, in so many ways, we're teachers, we're educators, and so we have to make sure that we're parlaying that information in a clear and concise way to our patients.
And Kathy, your patients will benefit from your own experiences, and thank you for being vulnerable and sharing that with us. That's really powerful. Do other groups have patients that come to mind when they're hearing stories like this? Scott, you look like you wanted to say something.
No. Scott Kramer, yes.
Scott Kramer.
To Scott.
So in my experience, I work with almost all bone marrow transplant patients. So I don't know that it's necessarily a fear of occurrence or reoccurrence so much as post allo transplant, that fear of the GVHD, steroid treatment, steroid myopathy. There's a lot of fear of, man, I've gone through transplant, I've made it home. That fear of having to return to the hospital. Because when that acute GVHD sets in, I have a patient right now who she's battling fatigue and motivation. She's gone through her induction, she went through her transplant, and now she's back because of acute GVHD, and there's no end in sight necessarily. And when you have to come back for that, it's so much more difficult, because when you're here for transplant, they say, hey, you're going to be out of here in 15 to 20 days or whatever. When you're here for acute GVHD, you could be here for months. And so that's what I battle a lot of, the fear of the unknown, and that's even with recurrence, there's the fear of the unknown. So I see it, it's just a different patient population, but it's a challenge that's, you have to keep coaching them, be positive, let them talk. And I always say, I'll be a sponge, you talk and I'll listen. It's just one of those things where they have to ask the right questions. You touch some difficult spots at times, but at the same time, if you get them talking, that's sometimes half the battle. So.
Yeah, I'd like to add something to that. That's thanks, Scott, for that. But it's also when you want them to tell you things, like, you know, especially if they've sought out other alternative things, you know, in addition to the traditional medical treatments, you want to create an environment where they feel comfortable telling you about it. So it has to be done in a way where there is not judgment, you know, and that you respect, you know. When I find someone who's gone on, you know, to the Dr. Google, you know, search, and they come up with all this stuff, the first thing I say is, wow, this is, you know, I'm so glad you've taken such an interest in this. You know, you're really seeking out information, you know, just to affirm that. And so that's one thing, so that they feel like, oh, and a little more open to saying what they're doing. But the other thing is that belief, they may have a very strong belief in what they're doing, and that belief counts. So you have to honor that belief. So a lot of times it's a negotiation, as far as I'm concerned. I try to get them to tell me as much as they can. I try to be non-judgmental. And then it's like, I have to really feel out, well, how strongly do they believe in this? And how open are they to, you know, really my job is make sure they do no harm, right? No harm's being done. No interactions are happening with their other treatments. So it's like, so honoring that in them is important to state that, so that they feel, again, that they can trust what you say, what we say to them.
Yeah, no, yeah, great points, Maura. And again, Scott, you know, you brought up a great point in the sense of, you know, fear of recurrence can look differently, you know, to different patient populations, right? And I would also argue that, you know, fear of recurrence can look differently within the same patient over different points in that person's life. You know, I think of, you know, somebody who is a young adult survivor, you know, somebody who's diagnosed in their 20s, you know, and so they're, you know, are they concerned about fear of recurrence at that point, you know, as far as like, you know, trying to set up the rest of their life at that point, and then, you know, maybe that goes away, maybe it kind of like, you know, kind of you know, kind of subsides a little bit, but then what happens when that survivor has a family? You know, does that, then the fear of recurrence comes back up, because now they're saying, well, what do I need to do to make sure that I'm around for my family? What do I need to do to stay around for my kids? And so, you know, I would also argue that as well, that, you know, the fear of recurrence can look differently patient to patient, but it can also look differently within the patient themselves.
I'm just going to say real quick too, one of the beauties of the interprofessional team is that the patient is hearing the same information from a united front. I think that's part of the frustration with patients, is there's the fear of the unknown. Fear of recurrence is something that could happen in the future, so no one really knows. There's a lot of data that you can share, but you hear different messages from the doctor, then from the nurse, and then Dr. Google, and then the therapist tells me something else. And so to have a team all on the same page is really helpful. So
yeah, I think as a medical profession, we could do better too at streamlining this, because sometimes I feel like fear is leveraged, right? Like, if you don't do this, the cancer's going to come back. And so, you know, I'm going to capitalize on that fear to try to get you to do the recommended treatments. And I feel like we've fallen short with sometimes how we've presented information. And so patients walk out absolutely terrified. And, you know, and so that's a different echo, but
no, that's a great point though too. And also information overload. When is it the right time, or dosing it, or you know, I told you that back at your initial diagnosis. Well, yeah, you told me a lot of stuff. And
yeah.
when is the right time to continue to reinforce and make sure you're saying the same thing, that the message is consistent?
Yeah, agreed.
This is a great discussion, and I love it. I want to make sure that we do have a little bit of time to actually get to our didactic, and then we'll have time for some Q&A after that as well. So Jevin, if you don't mind firing up the didactic now, we can take a few minutes and kind of go through our slide presentation.
Sure thing. I have it right here. So just to, again, address the agenda for today, we'll spend about 15 minutes on this didactic and have some time left over for some questions and answers at the end. As you've seen before, no financial disclosures for this presentation today, and we are talking about fear of cancer recurrence. So I was going to kick things off with this and mention to start that fear of cancer recurrence, it's pretty self-explanatory in the name alone of what it is. It's the fear or worry that someone's cancer could return. And it occurs in about 50 to 70% of cancer survivors. And frankly, not enough providers are addressing it with their survivors. And as you can see here, 60% of providers are not asking about fear of cancer recurrence. And there are a number of small studies that have been done looking at interventions about reducing suffering from it. As a matter of fact, there was a literature review in 2018 that looked at 7,000 articles, and it was clear that more research and interventions were needed. But ultimately, brief counseling from healthcare providers or use of various online tools can be beneficial. And there were a few studies, one looking at testicular cancer survivors with electronic web-based interventions, and then another one, the Recurrence trial for breast cancer survivors. The ETC showed improvement in fear of cancer recurrence, but the Recurrence trial did show that there wasn't as much difference in looking at usual care versus the intervention with the online self-help. So it really just, again, highlights the importance of counseling by a healthcare professional as well. It's important to note a few things when you're addressing fear of cancer recurrence with your survivors. It's important to, one, notice in their history, do they have any other mental health conditions like depression or anxiety, for example? And then it's important to follow up on those emotional cues that they are presenting with at the time of the visit. You want to give them the time to experience that emotion and then validate that emotion with them. Something as simple as, I can see that you're sad. I can see that you're frustrated. That goes a long way as part of the therapeutic listening and echoing back what they're feeling. If I can leave you with one big takeaway here, it's that fear of cancer recurrence is a normal experience for cancer survivors. And it's important that they seek help should this be starting to interfere with their quality of life. And lastly, I wanted to talk a little bit about some of what goes into addressing fear of cancer recurrence before the rest of my team goes into it more as well. There was a survey shown that 80% of cross-sectional surveys of cancer survivors revealed that receiving factual information about risk of recurrence can be helpful, particularly thinking about their prognosis and, again, that risk of recurrence. So really effectively communicating that is key at the time of the visit. And if there are questions that come up that maybe are outside of your scope or you don't know the answer to, directing them to the appropriate party, say their oncology team, for example, or their medical oncologist, can be helpful. Another thing that so many survivors come through our clinic asking about are, what should I be looking for? What symptoms are the ones that mean my cancer could be coming back? And this can be a point of anxiety, so making sure you're addressing that at the time of the visit is important too. A lot of times they'll think, oh my gosh, I have just, some hyperbole here, but I have a runny nose. Does this mean my cancer is coming back? So addressing that is important and can reduce some anxiety. And then, of course, recognizing that other healthy lifestyle behaviors can reduce recurrence itself too. Addressing their follow-up schedule with their appointments, their labs and imaging, and the rationale behind it is important. And really utilizing that as a point of focus that they can control for reducing their risk of recurrence and staying on top of any concerning symptoms. So with that, I'm going to turn it over to Angela.
Hello. Okay, All right, so again, fear of cancer recurrence. It's pretty obvious what it is by the name, but it's really just the fear, worry, or concern of the possibility that cancer could come back or recur, progress. It's important to note that fear of cancer recurrence is one of the most commonly reported psychological problems experienced by cancer survivors. And it's also important to note that 30% of cancer survivors that are surveyed indicate that managing fear of cancer recurrence is one of their most unmet needs. And fear of cancer recurrence does affect between 50 to 70% of cancer survivors across all cancer subtypes. Next slide, please. Okay, it's also important to note, again, as Jevin indicated, fear of cancer recurrence is common and normal to experience some level of fear of cancer recurrence. I can't tell you how many cancer survivors that I meet have at least some level of fear of cancer recurrence. I would say that it's probably most people have some level of it. It's very rare that I'll speak to somebody who has no level of it at all. I'll never forget, we saw a 30-year cancer survivor in our clinic, and he too thought about it sometimes. With the lower levels of fear of cancer recurrence, they can be really adaptive and encourage those positive health behaviors that Jevin spoke about: exercise, eating healthy, making healthy behavior changes. 22 to 87% of cancer survivors report a moderate to high level, on average 49%. And as Tara spoke about, fear of cancer recurrence is not strongly linked to prognosis and may even occur in individuals with a relatively good prognosis. Besides the Survivorship Clinic, I do work in the Yale, the Smilo Breast Center. And I have found that my work with breast cancer survivors, women that have stage 1, stage 0, have really good prognosis. They tend to sometimes have really high levels of fear of cancer recurrence. Next slide. So who's the most at risk? So these are just some things to keep in mind when you're meeting with survivors that could potentially put them at risk for developing fear of cancer recurrence. A younger cancer survivor, okay, so again, the woman we spoke about, her initial diagnosis was in her early 40s, higher subjective risk perception, more severe side effects, anxiety conditions, or past mental health issues before their cancer diagnosis, someone who has a past trauma, or has relatives that are developing or dying from cancer. Again, our case presentation, the woman's mother died of breast cancer at age 63, and then she had several other relatives who also had cancer. Next slide, please. So with fear of cancer recurrence, what does it look like? Well, really, it's on a continuum, and it fluctuates between functional and dysfunctional anxiety that can really impact all areas of life. And it's been associated with psychological distress, sleep disturbances, issues with concentration, functional impairment. You know, these would be patients that have excessive reassurance-seeking behaviors, to the healthcare providers. And in extreme cases, fear of cancer recurrence can develop into anxiety disorders, post-traumatic stress, and even depression. Next slide. So let's talk about the different levels really quickly. For the mild form of fear of cancer recurrence, which again would be what most survivors experience, this is someone who has occasional thoughts that cancer could come back. And it's usually because of external triggers like follow-up appointments or hearing about a new cancer diagnosis from a family member or friend. And usually this improves over time and really goes away on its own. And overall, the survivor seems to be coping and managing well. With a more moderate to severe form, this would be somebody who's experiencing frequent thoughts about cancer that happen more than once per week with the absence of any type of trigger. And they have this perceived inability to control these thoughts and a strong sense of distress that's associated with them. Next slide. And our case example, she would be somebody who I would say had this more or less severe, highly disabling form, which affects about 7% of survivors. Somebody who has constant intrusive thoughts, a preoccupation that the cancer will come back regardless of their prognosis, over monitor for signs of cancer activity, impairs their daily functioning, again, overutilizes the healthcare system, or they might be somebody who's fearful and avoids coming back for those follow-up appointments and cancer screenings. They have unhelpful coping behaviors. They have a hard time planning for the future because their plans could be disrupted. And again, constantly searching online, that Dr. Google, related to what's the best and latest form of treatment and prevention. And unfortunately, somebody who's experiencing this level, it's unlikely to go away unless there's some type of clinical intervention, meaning mental health services, like a therapist, a psychiatrist, and so forth. Next slide. So how are some ways that we can help cancer survivors cope with fear of cancer recurrence? Well, obviously referring them to a cancer survivorship clinic. I guess we're just a little biased about that, but also referring the survivor for an evaluation by a clinical social worker or a psycho-oncology provider, suggesting that they reach out to a community mental health professional for some counseling, referring them to a local cancer support group, and also, again, encouraging those healthy, positive health behaviors, including healthy eating, exercise, and learning mindfulness meditation. Next slide. Maura.
Okay, so let's just, thanks Angela. Let's just take another look at how fear of recurrence can manifest in nutrition. So next slide, please. The fear of recurrence can, in next slide, turn into an actual fear of food. And this is where I see people really restricting their food intake and winnowing it down to a very few food items, and also can concurrently be increasing their supplement usage. So that's often how I see fear of recurrence manifest itself, and it can actually become a form of disordered eating. And we actually have a working term for this, which is orthorexia nervosa, which is a compulsive, compulsive behaviors and a preoccupation with food restrictions. But the goal is to be clean and pure. It's not for weight management. It's not like a anorexia nervosa where someone's really trying to lose weight. It's not a binge eating disorder. It's like using food as a way to purify the body. It can be, when you meet up with it, it's quite powerful. Next slide, please. The other big trigger of fear of recurrence is this notion that sugar feeds cancer. I get this a lot. So I try to be very concrete with people. When they say, does sugar feed cancer? I just say, no. It goes a long way. Do we need to limit added sugars? Well, absolutely. For overall health, everyone needs to. So there is a healthy amount of sugar, added sugars, fun foods that we can have in a day. And the American Heart Association has actually quantified it for men and for women. Women, you can talk about it as it's 100 calories worth of sugar, or it's 25 grams, or it's 6 teaspoons. Men get more. Is it unfair? Absolutely. Women deserve it more. So, it's just another one of the unfair things of life. But I have people come in with this notion, this is a real hardcore one, of sugar feeds cancer. And I've had people cry in my office saying, I just couldn't take it anymore. I had to have a Snickers bar, and I bit into it. And I burst into tears because I thought, oh, I'm going to bring my tumor back. Like there's this direct line. And I have to be very concrete with them. And I've had not only tears of suffering for this, but also tears of relief when I explain to them there's not this direct line. Next slide, please. So the way I try to explain it to them, I'll try to explain it to you, is, a normal cell that turns into a cancer cell, it takes time. And, it's a slow process that can occur, varying, but it occurs over time, over years. So what you eat and your activity can impede this process. It can slow it down. It can interrupt it, in a positive way. So a healthy diet and good activity can actually slow this process down. And we call that like an epigenetic effect. So it's not like this direct line, I eat a Snickers bar, it goes right to a cancer tumor. It's more, the overall effect, the overall protection of eating well and exercise over time. Next slide. And so again, the other manifestation is supplements. And oftentimes people come to me just with that question, what supplements should I be taking? Yeah, they totally expect that's what I'm going to tell them, not what foods should I be eating. So just so you know, the party line is we use whole foods to obtain our micronutrients, and we do not use supplements to protect against cancer. There is this misconception out there, this myth, well, if some is good, more is better. And that is just not true. We don't need these in large amounts. So my first job is to first do no harm when people report their intake. However, this is a robust consumer market, and it's projected $300 billion in sales. That's with a B by 2024. Next slide. And just so you know, we do know how much we need of vitamins and minerals, all right? It's called the dietary reference intakes. There are these beautiful tables. They're organized by age and gender, and it's defined as how much is needed to meet the requirements of 98% of healthy adults. We also know how much is too much. Another set of beautiful tables to look this up, and we call the tolerated upper intake level, and it's defined as the highest daily intake likely to pose no risk of adverse health effects. And these are put out by the Institute of Medicine. So I use these all the time in my practice. So someone will come in and say, well, I take selenium. And I'll say, well, how much? And they'll say, oh, like 3,000 milligrams. And I'll pull out the table and I'll say, well, you only need 30. And they're like, what? What do you mean I only need 30? And I say, well, you only need 30. Why are you taking 3,000? And they're like, because it was on the shelf. And then their question to me is, why is it on the market? And I say, because it can be. It's the way the regulation is set up. It's really incumbent on the manufacturer to put out truthful information. And that's not their goal. Their goal is to sell products. So next slide. So the big concern with supplements is that it can interfere with prescribed medications. And they share, the way this happens is by sharing common metabolic pathways. I kind of describe this like merging traffic on a highway. So you can either increase the effective dose of the other medication, or you can decrease it. It works either way. Next slide. That's it for me. So I'm going to pass it off to Scott.
All right, thanks, Maura. So, when I have a survivor sitting in front of me, and assessing, what is their level of fear of recurrence, you really do have to kind of start from the beginning, and get a sense of what is their exercise history, or their rehab history. Is this a new behavior that we're seeing, as far as like whether they are exercising more, or if they're exercising less, or has this been pretty consistent, for several years leading up to, when we might meet them for the first time. And interestingly for me, I kind of break it down into a couple different scenarios. I kind of feel like I see a couple different types of individuals when they come in. I get the person who has never exercised before, and so their argument is, well, I still got cancer, even though, so why should I bother now? And then I get the other end of the pendulum is we get the person who says, I was always exercising, and kind of like our person that we described in our case study, I did everything right and my body still betrayed me. So then why should I even bother resuming exercise? Or you might get this person who says, and this is probably the biggest piece of the pie, as far as the biggest question that I get asked is, I know I need to exercise, but I don't know how to start or restart, or I don't know what's safe. And so again, this is our role really as teachers, to talk about how to educate our survivors moving forward with a safe exercise protocol. So if we go to the next slide, I referenced these new recommendations from the American College of Sports Medicine at our last ECHO session, because now we are talking about having targeted exercise interventions for our survivors with these new guidelines that came out in the fall of 2019. This international think tank came together and updated the recommendations from 2010. And those 2010 recommendations were very general. They actually used the general guidelines for the general American population when they said, we're going to do 150 minutes a week of cardio and that's it. This is a lot more targeted. And so our contribution as PTs to our patients who are experiencing fear of recurrence, who are experiencing increased levels of anxiety and depression because of their cancer diagnosis, we now have targeted exercise interventions to help address this. And I find this fascinating that we can address this through rehab. We can address this through exercise. And interestingly enough, if you put these recommendations for anxiety and depression up against cancer-related fatigue, like we talked about 2 weeks ago, for cancer-related fatigue, the cardio was actually less, and they talked about having strength training as part of the protocol. With anxiety and depression, it's different. So again, it's targeted. They actually want our survivors to do a little bit more cardio. There's more research to back that up. But there's not enough evidence at this point anyway to show that strength training, or at least strength training alone, is enough to make a significant difference in somebody's level of anxiety or depression. So, when we're designing an exercise protocol for our patients, we definitely want to be skewing them more towards the cardiovascular exercise if they're exhibiting these heightened levels of anxiety and depression related to their cancer diagnosis. Next slide. And one of the other graphics that came out from all these papers that came out in the fall was, when we talk about the fear of recurrence and trying to help prevent the cancer from coming back, they came out with very specifically to say that there are 7 types of cancers that can be positively affected by exercise. And so to talk to our survivors about that and say, listen, we can talk about, if you're concerned about developing a secondary cancer or another primary, being able to exercise is going to help reduce your risk of getting these other diagnoses. And so that's how we can sell rehab and how we can sell exercise to our patients when we're talking about fear of recurrence. Next slide. So that is our didactic presentation. We'd love to open it up now for some more questions. We have some time. What did you guys think about this? Did it make sense, all of us coming at it from our different angles and our different perspectives, our different professional approaches to address the fear of recurrence? Did it all make sense? And do you have any questions or any comments or any other patient scenarios that you want to share with us in these last couple minutes?
Looks like Amy had raised her hand. Amy, go ahead.
You guys had mentioned that prior to you seeing her, she had been offered counseling services. After you guys saw her this time, did she take anybody up on that offer of psychosocial oncology services or counseling services to assist in any of these areas?
So Amy, I'm this.
Oh, Angela, looks like you're breaking up there. Oh, Angela, we can't hear you. Hold on one second. I'm going to ask you to unmute maybe on the phone, if that might be better. There we go.
What? I'm sorry, Amy. Okay. Sorry, I have my phone and my computer going at the same time because I'm having these connectivity issues. So anyway, so I actually didn't see her, but what I know about her is that she was in fact, that she did meet with a social worker from that clinic, and my understanding is that it was encouraged and she declined it. And how I knew that was based on some other notes and visits and things that have happened over the years, because it wasn't just the survivorship team that I believe who had encouraged it. It was also other professionals as well who she had been seeing and speaking with. So unfortunately, I didn't get to meet her to explore maybe she had a really bad experience or something. Who knows why she didn't want it, but it would have been nice. I would have liked to have met her to understand why she wasn't interested.
Yeah, I'd be curious as well. And then even if she wasn't interested, how do we bridge the gap with some patients revolving the stigma of counseling and just psychology or psychiatry services? I think I know with a lot of my head and neck patients, that's an area that I think would really benefit from a lot of their assistance. And we have a counselor in our survivorship program. And so she's often utilized a lot. But like you said, you do run into patients that you feel like this may be like the number one treatment that would really make a huge difference for you.
Yeah.
But how do we bridge that gap?
Yeah. And right. And I think it's just, if I would have met her and she was resistive, I would have just taken the opportunity to talk to her about, provide information and education, and share with her my concerns, like the things that I'm seeing as an outsider and how it's impacting, her ability to function and her quality of life. But I'll be honest with you, as a mental health professional, every once in a while, you do meet somebody who just does not want treatment, no matter how badly they would benefit from it. And so my sense is this is one of those people that she just, for whatever reason, doesn't want to have some counseling.
Yeah, we have a lot of other patients that run into like the financial strain of counseling services. So whether their insurance covers it or not, and the availability of our oncology counselor specifically versus a general mental health practitioner. So I don't know if you guys run into like the financial barriers revolving around insurance with that service in particular for your.
Sometimes I do. Sometimes I run into that with patients, but it's not. It doesn't happen that frequently. It is a factor though that can impact them wanting to seek some counseling. Oftentimes though, I'll ask them, a lot of times people work for big enough companies that they have an employee assistance program. And so usually you'll get 5 or 6 free sessions through that. And if really it continues to be the fact that they can't pay that copay, we do have social workers throughout Smilo who can provide some supportive counseling services, not ongoing to the level that like a mental health professional in the community could provide, but that's also available. Or, encouraging them to go to a support group as well can sometimes be helpful.
Yeah. Well, thank you.
All right. Great question, Amy. Thanks for bringing that up.
Thank you.
Any other thoughts, any other questions or patient scenarios that this strikes a chord with you guys?
We have a comment from the chat.
Oh, you're welcome. I'm glad.
You guys.
We're glad that you enjoyed it. So I'll take these last couple of minutes to remind you guys of a couple things here. First of all, Devin will be sending out following our session today our questionnaire, our post echo session questionnaire and needs assessment. So we ask you to take 5 or 10 minutes to please fill that out, because it really helps us. As we continue to shape these echo sessions. We learned a lot from the session that we did in the fall with the oncology certified dietitians around the country. And so we put a lot of that into this session now for our group. And as we continue to move forward, we'll be using that feedback. So please take a few minutes to fill out that information. Wanted to also let you guys know we had been going every other Wednesday, but with the upcoming July 4th holiday, our next session, echo session number 5, is actually next Wednesday. So instead of skipping ahead 2 weeks, we're going on next Wednesday, 3 o'clock Eastern, 2 o'clock Central, for our next session, which will be on energy balance and weight management. And I wanted to throw out quickly, to you guys, and you don't have to answer right now. You can either send Jevin or I or an email as a follow-up. Our last session is kind of a wild card. We intentionally did not have a didactic planned because we wanted to see, what could we bring to you guys? What do you want to learn about in that last session? And I'll throw out two examples to try to get the ideas going. With our fall group, we offered our last session was on sexuality and cancer, and how the multidisciplinary clinic addresses those concerns that so often don't get addressed in those follow-up oncology visits. So we could talk about that, and we can bring in some of our experts that we have in our system to talk about sexuality concerns for cancer survivors. The other option could be that we could bring some of our colleagues who deal with integrative medicine within our cancer institution to come and talk about what they do and how, again, we can integrate complementary medicine into survivorship care and to long-term survivorship care. So those are two examples, but if there's something that's really interesting to you guys, please email Jevin or myself, and we'll make sure that we get the ball rolling for that, because that last session will be July 8th. So we have a little bit of time to plan for that. And so with that, I know it's 4 o'clock on the East Coast, at 3 o'clock Central Time. So we thank you guys for spending an hour of your day with us. This is great dialogue, great conversation. It's been a pleasure. And so I ask you guys all to be healthy and stay safe. And we will see you guys back here 1 week from today, 3 o'clock Eastern, 2 o'clock Central, okay? Have a good afternoon, everybody.
Thank you. Great job. Bye, you guys. See you next week.